Paolo Dell'Oglio. Once again, congratulations for winning the Best Robotic Paper Award published in European Urology, and on the behalf of Vattikuti Foundation, we really congratulate you on this amazing competitive feat. Tell us something about yourself and your journey so far in the field of urology.
First of all, I would like to thank you for this award. I'm very honored for this. Well, I'm a full-staff urologist at Radioguided Hospital in Milano under the supervision of Dr. Bocciardi. I did my residency in San Raffaele Hospital under the supervision of Professor Montorsi and Professor Briganti Alberto. During my training, I moved to Canada in Montreal 1 year to do clinical research with Professor Pierre Carakiewicz, and I learned a lot of stuff using RStudio, and I published several papers especially on kidney cancer and prostate cancer. Thereafter, I moved 1 year in Paris, in Montsouris, under the supervision of Professor Catelino, Eric Barret, and Rafael Sanchez Salas. I was trained in lap and robotic surgery. Thereafter, I moved back to Milan for 1 year, and after 1 year, I moved to Aalst in Belgium. I did 1 year of fellowship in robotic surgery under the supervision of Professor Alexander Motry. He taught me everything in robotic surgery, and after 1 year, he asked me to stay there and to become part of his staff, and so I decided to stay there for 1 year and complete my full training in robotic surgery. For personal reason, I decided to come back to Italy to follow my family, and now I'm part of a Radioguided Hospital in Milano with Dr. Bocciardi and Dr. Calzano, that are my mentors.
This question is very specific to your work, which definitely has immense effect on the patient outcomes. Could you please explain in simple language your work on drop-in probe and how it's going to improve the yield or pickup of sentinel node invasion in these patients?
Thank you very much for your question. The aim of our study was to confirm the utility and safety profile of a drop-in gamma probe for sentinel node biopsy in patients candidate to sentinel node biopsy and lymph node dissection during radical prostatectomy. We know from the literature that up to 30–35% of positive lymph nodes can be missed by standard template lymph node dissection. And we know that sentinel node biopsy can help surgeons to reduce these missed positive lymph nodes. There is evidence that sentinel node biopsy can help in open and laparoscopic setting. The evidence is also available in robotic setting. However, we know that the laparoscopic gamma probe has some limitation. For example, the reduced maneuverability of a probe. If you think about the trocar placement, and the assistant is on the right side, also during robotic surgery, the reduced maneuverability of the probe is especially on the right side of the patient, on the iliac lymph nodes, external iliac, internal iliac lymph nodes, obturator right lymph nodes, and common lymph nodes. Therefore, to overcome this reduced maneuverability of the laparoscopic gamma probe, we decided to develop the drop-in gamma probe that allows first to overcome this issue of a reduced maneuverability, and second, to overcome the fact that the laparoscopic gamma probe is used by the assistant and not by the consult surgeon. In this study, we performed for the first time ever a comparison between the sentinel node identified by the drop-in probe versus laparoscopic probe versus fluorescence imaging. Specifically, we evaluated 25 patients treated for sentinel node biopsy plus lymph node dissection and robot-assisted radical prostatectomy. All patients were treated by 3 surgeons, 3 expert surgeons, and SI system was used. All patients underwent preoperative intraprostatic injection of hybrid tracer, specifically ICG plus technetium. And after 15 minutes, we perform lymphoscintigraphy, early lymphoscintigraphy, and after 2 hours, we perform late lymphoscintigraphy and SPECT-CT to have a preoperative mapping of our sentinel nodes. Thereafter, after 5 hours, radical prostatectomy was performed. We started with sentinel node biopsy, and thereafter we did lymph node dissection and finally radical prostatectomy. All sentinel nodes were pursued by first drop-in probe, thereafter by laparoscopic probe, and finally by fluorescence imaging, specifically using the Firefly of a robotic camera. Of all sentinel node pursued by drop-in probe, 100% were identified by our drop-in probe, 91% were identified by fluorescence imaging, and only 78% by laparoscopic probe, underlying the higher sensitivity of our drop-in probe relative to the laparoscopic probe and the fluorescence imaging. I strongly believe, and there is also evidence, that the combination of the drop-in probe, so the acoustic and numeric signal to identify the sentinel node, must be combined with the fluorescence imaging that give us a confirmation of the sentinel node. I believe that there is also evidence on this that the future will be the use of the future for robotic surgery will be the use of this drop-in probe with PSMA tracer.
In your paper, you emphasize the comparison between the rigid laparoscopy probe and your drop-in probe. How much is the contribution of flexibility of a drop-in probe to position vis-a-vis combining it with ICG?
Thank you very much for your question. Well, we provided evidence that of all sentinel node pursued by drop-in probe, 100% were identified by drop-in probe, 91% were identified by fluorescence imaging, and 70%, approximately 71% were identified by laparoscopic gamma probe. I strongly believe that, and this is also what was identified in our previous paper, that the combination of the drop-in probe, so the acoustic signal that identifies the sentinel node biopsy, must be combined with the fluorescence imaging that allow to improve sentinel node biopsy identification, because give us an optical identification of a sentinel node.
As you know, Vattikuti Foundation involves in supporting cutting-edge research in computer-assisted surgery, and our focus is the patient outcomes. Research could be a dead end, a passion for the researcher. We try to assess how it impacts the quality of life of the patients or the outcomes. Can you tell which specific group of cancer prostate patients are likely to be benefited by picking up the nodes which are currently missed by conventional imaging, and how you anticipate the outcome of these patients would improve?
Thank you for your question. Well, we believe that all patients that are candidate to lymph node dissection, so that have a risk of LNI more than 5% according to Briganti nomogram, should undergo to this procedure, especially higher risk patients. PSMA, preoperative PSMA might help a lot on this. And there is also evidence we recently published with the same group. The first name of the paper is Mazzone. Me and my friend Elio Mazzone work on this a lot, and we recently published that the combination of a hybrid tracer, not only the technetium but ICG combined with the technetium, might help to better identify sentinel node biopsy compared to the standard technetium tracer, and that the combination might also improve oncological outcomes. Obviously, our findings need to be confirmed in a larger sample size.
I see that though you have worked mainly in lymph gland pickup in cancer prostate, but don't you think this work has a larger implication for gynecological cancers and other things?
For sure.
Yeah.
There is also evidence on this, and we are improving the evidence available. We finalized the analysis, and we are writing a paper on vulvar cancer, head and neck cancer, and melanoma cancer. So yes, the image-guided surgery might help to improve oncological outcomes also in our setting.
Thank you very much, and once again I bring compliments from Vattikuti Foundation, and thank you for such a wonderful research work which, according to me, has pushed the boundaries of knowledge in urology, and we hope you continue to bringing new dimensions to the practice of urology. Congratulations and thank you for your time.
Thank you very much.